So today, I think sort of echoing, but in a sort of my own, in a different way, I'm also going to talk about ways in which the concept of autism has evolved and changed, and also the ways in which it needs to evolve further. And that's partly, I suppose, to give us all a bit of a shared sense of, you know, what autism is and who may well be autistic and who might benefit from an assessment, which I think is, as we've already discovered today from hearing Professor Morgan talk, from hearing Kathy talk, from hearing many others talk, it is often a key issue that people are actually entering services undiagnosed. I'm then going to go on and talk about the female autism phenotype, which is my sort of somewhat kind of technical researchy phrase for this question of whether there is a female-specific presentation of autism. And we're going to have a think about that. Now, I don't want to give the impression that we should ignore the eating difficulties of boys and men, you know, because I think that is an important area, and my understanding from the eating disorder world is that they are an underserved population. But it is the case that if we're thinking about who is presenting to eating disorder services at present, it's very much a preponderance of women on the autism spectrum rather than males. So that's why we're focusing on that today. And also that's where our kind of research that Charlie and Janina are going to present for you after the break is really honing in on and focusing. I'm going to say a little bit about autism and eating difficulties, and then I'm going to be the sort of the warm-up act for Charlie and Janina, who are going to come on after the break and tell you about some of the things we've been discovering in our work in this area. So I'm going to kind of set up why we were doing the study. And like Claire, I'm going to be using identity-first language. I'm going to be talking about autistic people rather than a person with autism. I don't know about you, but I found that quite a hard transition to make as a clinical psychologist, because I was very kind of carefully trained to use person-first language. And I think if I turned up on placement and said, oh, so am I seeing a schizophrenic patient today, I probably would have been kicked off the placement by half of my supervisors. It would have been seen as very disrespectful. What's interesting is that in the autism community, there's a growing desire for identity-first language. Firstly, because we tend to only use person-first language for conditions that are negatively thought of. So we don't say a person with intelligence or a person with good looks. So an autistic person would say, well, why are you saying a person with autism? I don't accept that autism is inherently a disorder, a problem, a bad thing. And I think it also reflects the idea that for so many autistic people, their autism is not a sort of optional extra. It's fundamental to who they are. You know, so the idea of them being a person with autism doesn't really make sense to them, because they see it as very often, I mean, not everyone, but very often see it as fundamental to who they are. And I thought this was rather nicely illustrated to me. I was out on a walk with an autistic friend of mine, and he put it to me this way: I'm an autistic person, but I'm a person with OCD and generalized anxiety disorder. So that helps me to kind of understand and to finally make the switch to identity-first language. And there's an interesting paper on this if you'd like to sort of know more about the debates in this area. Okay, so the birth of autism. So this here, this rather good portrait is of Leo Kanner, who was the first person to kind of bring autism as we think of it today to the attention of clinicians and subsequently researchers and the broader public. And he was a German-trained psychiatrist working in Baltimore, having fled Germany due to the Nazi persecution. And he became a very, very eminent clinician. He ran this clinic at Johns Hopkins University, and he noticed a certain pattern of kids who were coming through his service. He noticed certain characteristics they had. And Donald, this lad Donald here, is sort of, if you like, a typical of these young people that he was seeing. So Donald was happiest when left alone. He made stereotype movements. He spun with great pleasure. He was said to have words to him had a literal inflexible meaning, as Kanner understood it. And when taken into a room, he completely disregarded the people and instantly went for objects. So this was the kind of Kanner view of autism. And this is, in fact, Donald, who was the first person in the world, as I understand it, to be diagnosed with autism or as autistic. And Kanner kind of solidified these views, and he wrote this famous paper here that starts with this rather memorable sentence that in some ways kind of kicks off this whole kind of field of autism research and clinical practice, since 1938 there have come to our attention a number of children whose condition differs so markedly from anything reported so far that each case merits a detailed consideration of its fascinating peculiarities. And Kanner and his colleagues decided that autism fundamentally had two characteristics. Yeah? One was what they called an inborn autistic disturbance of affective contact, a kind of difficulty in forming socio-emotional kind of bonds with people. And the other sort of type of characteristic of autism, as Kanner and his colleagues saw it, was a powerful desire for sameness. And in one sense, those views still prevail today. Because if you think of the kind of modern, clinical, at least, conception of autism, there's this notion that there's this kind of thing called autism, which is presumed not to be sort of, if you like, directly observable, but is in some sense manifest in the structures and the function of the brains of autistic people. But that this gives rise to two types of what you might call within a medical model symptoms, or what we might call characteristics. And so there's one cluster of characteristics which are to do with the social world, forming relationships, social communication. And then another bunch of characteristics which we might call non-social characteristics, which aren't directly to do with the social world, to do with dislike of uncertainty, and also a kind of a particular style of sensory processing. So in that sense, Kanner's original view of autism is still very central to mainstream views of what autism is today. But I want to make the point now that there were many things about the conceptualization of autism that Kanner put forward and which then subsequently became the kind of consensus, the widely held view of autism in the kind of second half of the 20th century. So from the 40s, when Kanner was writing, right up, I would say, until the 90s and the early 2000s, that view of autism has come to be, I would almost go so far as to say obsolete. Has become sort of overrun with both evidence, scientific evidence, but also social and cultural changes that make it no longer sustainable. And this is the view I'm talking about. This is the old view of autism that I'm going to set about challenging now. So there's this idea that this is a rare and severe neurodevelopmental disorder, usually associated with intellectual disability and delayed language development, and categorically distinct from so-called normal development and from other disorders. And I'm going to go on now to argue that that notion of autism, which even when I came into the field as a research assistant at Great Ormond Street Hospital in London in 2002, was still very widely held, including by many of the most powerful people in the field who sat on the grant committees and had immense power over the shape and direction of the field. I'm going to argue this is based on a number of myths that have since been overturned by empirical evidence. So first one, the myth one, is that autism is rare. By the current diagnostic conventions, autism is not rare at all. It affects, or it is seen in 1 to 2% of children, and of course, it doesn't go away. Autism is a lifelong state of being. It's a lifelong characteristic, so it also affects 1 to 2% of adults. So this is not a rare state of being, autism. Obviously, many of you are autism specialists. Some of you are autistic yourselves. You obviously know many of you will know lots of autistic people. But these days, whenever I give a talk, even to general audiences, I always say, do you know somebody who's autistic? Have you ever met somebody who's autistic? And it's very, very common these days that most of the room puts their hand up. And that's right, because in pretty much every year at school and in pretty much every workplace and in all sorts of settings, there are autistic people. And so we cannot dismiss this as a kind of a rare condition. Secondly, myth number 2, most people with autism have intellectual disability. Well, actually, if you look at the data of the prevalence studies that are being done, when people go out into the community and attempt to identify all the children who meet current diagnostic criteria for autism, they tend to find that between half and 70% of those kids have an IQ in a normal range. They do not have an intellectual disability. And it's worth remembering that 70% of autistic kids in this country, and also 70% of autistic kids in America, and in most parts of the kind of so-called Western world, are in mainstream education. Yep. So again, this old-fashioned view that, you know, believe it or not, I have seen referral letters where this is kind of referred to, you know, oh, the child spoke, so they can't be autistic, or the child smiled at me, so they can't be autistic. That's an old-fashioned view. We have to realize that most autistic people have, regular IQs and fluent language. So this was something that Claire spoke about very eloquently, but I'm just going to sort of put it in my own way as well, which is myth number 3, that autism is just about having difficulties. And I think those of us in the research community, those of us who are clinicians as well, have a lot of work to do here to train ourselves out of this mode of thinking that autism is some sort of inherently kind of disordered state of being that is fundamentally about difficulties. Believe you me, that is actually quite a big cultural change that we're trying to make here. And what's interesting is that if you look at the research literature, people are so much more interested in the limitations of autistic people than in the strengths and capacities of autistic people. And that's a pretty lousy thing to do to someone, isn't it? To only be interested in their limitations and not their strengths. But there are a few studies starting to creep into the literature. Hopefully they will become more and more numerous in the upcoming years, where people have experimentally and formally identified areas of, if you like, superior function in autistic people. Things like open-mindedness. There's been studies where autistic people are found to be less susceptible to sorts of biases that can promote prejudice. Pattern detection. We've heard about flow states. We know that many autistic people have special interests that they pursue with great passion and expertise, and that can, of course, engender really wonderful abilities and expertise, and also things like detail-focused processing. So that's the third way, I would say, in which that view of autism, that old-fashioned view of autism, is just no longer tenable. So the other element of this view is that autism is a categorical disorder, that it's in some way a condition that is qualitatively distinct from the rest of human experience. A good example of a categorical disorder would be Down syndrome. Down syndrome is one of those conditions where you either have Down syndrome or you don't have Down syndrome. We're not all on a Down syndrome spectrum somewhere. People used to think that was the case of autism, but actually, when people have actually tested that out scientifically, they found very, very limited evidence in favor of that idea. And instead, they found evidence for the notion that autism is actually a kind of spectrum, a trait dimension that extends right through the population. And that there's no, if you like, natural cut point between people who are labelled as being autistic and people who simply have high levels of autistic traits. So there's this notion that, if you like, we're all on this scale somewhere, and if you get to a certain point on that scale where you have really quite high levels of autistic traits, it's a convention for you to, assuming you come across the right services and the right clinicians and so on, to be labelled as having this clinical condition, which is autism. It's a bit of an analogy with blood pressure. We all have a blood pressure number somewhere. We're all on a kind of sliding scale of blood pressure. Some of us have higher blood pressure than others, and there's been this sort of convention that if your blood pressure goes above a certain point on this sliding scale, then we'll put a label on that, we'll call it high blood pressure, and there'll be certain treatment implications. So, the 20th century review was that. I would say we've moved now towards quite a widely held consensus that autism is a relatively common neurodevelopmental condition, notice not disorder, usually associated with normal range IQ, although I do not wish to overlook or minimize the needs of autistic people who also have intellectual disability, that represents a form of natural human variation that brings both challenges and strengths. Yeah. And And within that framework, and with the sort of knowledge that autism is something that's constantly evolving, constantly changing, I'd like to talk about another way in which autism is evolving and changing, and another way in which it really needs to evolve and change a little bit more, I think, to meet the needs of autistic people. And that's about encompassing, understanding of, and sort of recognizing the certain kind of gender-specific characteristics and needs of autistic girls and women. And that's for me to be talking about the autism, female autism phenotype. So, I think a good place to start with whenever we think about the female autism phenotype is this here, that there is a diagnostic bias against girls and women on the spectrum. You know, and we've heard from Kathy today, who expressed, you know, with wonderful clarity, the sort of, well, firstly, in telling her story, the fact that she had been missed and she wasn't diagnosed till her late 40s, but also I think she conveyed, or certainly in my interpretation, of some of the disadvantages of having been missed, and actually how life might have been a bit easier if her autism had been recognised and supported properly earlier on. And in line with the sort of many anecdotal accounts we hear of autistic girls being overlooked, autistic women being overlooked, there is a clear scientific evidence that the gender bias against autistic women is real. So we know that autistic girls and women are less likely to get an autism assessment than are autistic boys and men. We know that if they do get an autism assessment and they get a diagnosis, they receive this later, on average, than do autistic boys and men. And interestingly, even when girls and women who have really high levels of autistic traits, you know, high levels of the kind of social characteristics of autism and of the sort of inflexibility and sensory processing characteristics, even when they do receive an assessment, if you're female, you're still less likely to actually meet current diagnostic criteria compared to a male with equivalently high levels of autistic traits. Yes, although if you then look at the levels of sort of functional difficulties that those girls have, and also if they're followed up later, you know, so it's quite common, for example, to have stories where you have girls who don't meet criteria 12 or 13, and then in early adulthood it becomes very clear.
in women compared to men, what we're potentially doing is crowbarring even more slightly different conditions that actually aren't autism and something else that probably should be recognised, dealt with as something else, even more into autism, which is already a massively overcrowded.
Can people hear this comment? Because it's a very interesting comment. I think, let me just paraphrase you, but I think you're sort of saying, isn't there a risk here that we're sort of moving the goalposts and you're kind of pulling in people into this condition and thereby making it broader and broader and thereby more heterogeneous? Yeah. Is that right? Yeah. And I think it's very reasonable because, you know, and I think you could say that for almost any condition because in a way, you know, depression is presumably very heterogeneous as well and can manifest differently in males and females. And I think it's a very important concern to keep sight of when we're thinking about shifting, whilst if I'm making an argument that we're underdiagnosing females compared to males. I think one way round this is that even if you're trying to change your diagnostic practice and you're trying to, you're working on this assumption that we're missing females and you're trying to change your diagnostic practice so that more of them meet criteria, you mustn't stray from the fundamental conceptual definition of what autism is. So an example I might give is I would still consider having a tendency towards special interests and focused interests to be inherent, to be important for an autism diagnosis. I wouldn't just say girls have less of those, so I'm just going to throw that out as a diagnostic criterion. But I would be more flexible about thinking about how that particular kind of characteristic might present in gender-specific ways. Yeah, but I mean, I think it's a really interesting point, and it's whenever you're working with a condition where there's no what they call biomarkers, there's no kind of blood test for autism or whatever, you are left with talking about the behavioural symptoms of the condition. So I would argue that there are two forms of bias that we're dealing with here, or rather that autistic girls and women are dealing with. We've got one which is a bias against receiving an assessment, and there's another bias against meeting the diagnostic criteria, even if you have very high levels of autistic traits, even if you do receive an assessment. And people are increasingly sort of aware of this difficulty and trying to tackle it. And the response people have had to it has to say, well, maybe the reason we're missing these females is because there's a female autism phenotype. That is a sort of gender-specific presentation of autism that doesn't fit very well our current diagnostic processes and diagnostic criteria, which, after all, were largely developed and validated on male cases. Yeah. So I'm going to talk a bit about some of the evidence for what this female autism phenotype might be. And just to sort of make the point, really, that this is an idea that is coming into, if you like, the mainstream of clinical practice these days. So, DSM-5 is not a book that's known for its kind of radicalism, and yet, you find this sentence in here: girls without intellectual impairment or language they may go unrecognized, perhaps because of subtler manifestations of social and communication difficulties. So it's pretty thin, and I think that's fair enough, because at the time when that was written, in the kind of 2010 to 2013, there was less evidence available, but there is acknowledgement that this is an issue that we need to address as clinicians. And I'm going to talk about a few characteristics of the female autism phenotype. I'm going to try and avoid making gross generalizations. I'm not trying to say all autistic women are like this, all autistic men are like that. Because obviously you will meet autistic men who show the so-called female phenotype. You'll meet some autistic women who show the so-called male phenotype. But we're talking about averages here. We're talking about tendencies. And I've also tried to draw out elements of the female phenotype that are evidence-based, where there has been some empirical work that has backed them up. And so the first one is that, on average, autistic girls and women tend to be more socially motivated than autistic boys and men. More interested in forming friendships and maintaining friendships, and more interested in, if you like, the sort of nature of the social world around them. And you could see how that could lead somebody to kind of overlook a potential diagnosis, because if you've got somebody who is struggling in school, who perhaps is suffering from sensory overload, anxiety, meltdowns when they come home, but they're a girl who does have another girl in her class who she sees as her best friend and they stick together like glue. If you had the sort of outmoded belief that autistic people are just not interested in the social world and cannot form any friendships, you could easily overlook that person as somebody who might benefit from an autism assessment. Another area of difference is in the field of special interests. So we've heard about special interests today and how these can sort of engender sort of expertise, and also they can be a really important part of autistic people's identity and a source of satisfaction and so on and so on. And I think many of us and many clinicians and diagnosticians and so on are pretty familiar with some of the so-called sort of classic autism-style special interests. Things like a kid who is obsessed with one particular line on the London Underground, or somebody who has a really kind of systems-focused mathematical or astrological sort of interest, or perhaps who's really into in an autistic way into particular types of computer games like Minecraft. I think those things sort of jump out at clinicians, and people are aware that they can be a sign that somebody might be autistic. What is interesting is that, again, talking on average, autistic females are less likely to show those so-called sort of typical special interests, and are more likely, surprise, surprise in a way, to have more sort of feminine, typical sort of special interests. So, obviously I've met plenty of autistic girls who really like Justin Bieber, or met some who've been really obsessed with Jane Austen. Animals, obviously, is a really important one. Manga. Many of you will have met, particularly teenage autistic girls who absolutely love kind of Japanese anime. And the point is that often their special interests are less sort of, quote-unquote, unusual in their sort of focus, and also often more socially oriented. So I've met plenty of autistic women who have an interest in something like anthropology or psychology or novels that are quite psychological, partly as a way to kind of enhance their understanding of the social world, and to kind of, quote-unquote, crack the code of the social world. And so you can see how those sorts of special interests might not kind of get people interested in the possibility of an autism assessment in the same way that somebody who is obsessed with, manhole covers or traffic lights or something like that. Okay, so another element of the female phenotype that I'd like to talk about a little bit is camouflaging. So what is camouflaging? So this was rather nicely summed up in the title of a study by one of my PhD students called Putting on My Best Normal. So we asked participants in this qualitative study, we call it camouflaging, what would you call it? And somebody said in this rather pithy and memorable phrase, well, I call it putting on my best normal. And the phrase you very often hear from autistic people is pretending to be normal. And that was, in fact, a famous book by Leanne Holiday-Wiley, an autistic woman who titled a memoir of hers, Pretending to be Normal. So when we talk about camouflaging, we're talking about things like masking, taking on certain behaviours to hide autistic characteristics, and compensation, developing strategies, behavioural repertoires, knowledge and understanding to help negotiate a kind of neurotypical world that can often be daunting and difficult and stressful for autistic people. So just to give you some examples, camouflaging could be as simple as, and this was one, she was early 20s by the time I met her, in an eating disorder unit, in fact, autistic, who remembered that as she was transitioning to secondary school, she began to notice that the stims that she liked to do, which felt really nice and were a nice way to kind of express emotion and to help calm herself, attracted a lot of attention from the other kids and looked unusual. And so she took a decision, I'm not going to stim in public anymore, I'm just going to stim at home in the privacy of my bedroom. So that would be a really simple example of masking, a form of camouflaging. It often involves the learning of social rules. If you like, using kind of if-then systems in order to kind of learn ways of negotiating neurotypical social code. So, many autistic people will have developed clever ways to kind of fake neurotypical eye contact, perhaps looking at the tip of the nose, or, I'm going to look in between the eyes for 3 seconds, then I'm going to look away for a bit, then I'm going to look in between the eyes for another 3 seconds. Rules like that. There's often quite a lot of mimicry involved, copying other people. There's often a lot of kind of almost sort of psychological, anthropological sort of systematic if-then rules that go into this. And it can sometimes result in the construction of almost a kind of persona, a mask that can be worn in certain situations. And the most striking example of this that I can recall, that I often mention in these talks, was, again, a young woman who I met in an eating disorder service, who had actually been diagnosed with Asperger's syndrome in her primary school years. And she remembered moving to secondary school, finding it very difficult, feeling out of her depth, feeling lost, really, socially. And her solution was to watch, or to pick one girl in her class who was the popular kid, and to watch her very carefully and to practice learning to imitate her. And this woman told me I would go home and I would practice her gestures in front of the mirror. And she would use, wear the same clothes, she got into the same bands and all this sort of stuff. And in the end, she developed a persona that was based on the imitation of this girl that she was able to put on and to use to navigate a social world that she found overwhelming and difficult. So who camouflages? Well, we've developed a questionnaire to measure this, and various other people have found ways to measure camouflaging, and unsurprisingly, autistic people camouflage more than non-autistic people, and people who have higher autistic traits camouflage more than people who have slightly lower autistic traits. We also find that individuals with higher IQs and with better executive function on the autism spectrum are more likely to be camouflaging. But relevant to our thinking here, women camouflage more than do men. So lots of autistic men camouflage, but autistic women and girls appear to be doing it even more. And I would consider this to be an important element of the female autism phenotype. And you could certainly see how camouflaging, somebody becoming skilled at effectively pretending not to be autistic, is going to get in the way of timely assessment and diagnosis. Just to say a bit more about camouflaging, based on findings from a qualitative study begun by Laura Hull, why do people camouflage? Why do so many autistic women and also many autistic men feel compelled to camouflage? Well, here are some quotes from our study. Camouflaging helps to survive in school and college, and it's important for keeping jobs. So there's a kind of practical survival element to it. And I think this comment is very striking. So why do you camouflage? I want to avoid the bullying, mostly. So, I mean, if you think about it, if we'd asked, gay women, saying, do you ever pretend not to be gay? And they'd said, yes, sometimes I do. And you said, why? And they said, I want to avoid the bullying. We'd have a word for that, wouldn't we? We would call that homophobia, we would call it a hate crime and so on. And so I think it's very interesting. To me, this research into camouflaging has given me a sense of the precarious position that so many autistic females occupy in a kind of neurotypical world, and to see camouflaging as a kind of attempt to survive that. Also more positive aspects of why do people camouflaging, it enables me to be with other people in a way that's relatively comfortable for me. So it can be a way to kind of build bridges with other people. What are the consequences of camouflaging? Well, the key thing that we hear time and time again is that it's exhausting. Yeah, that there's something utterly exhausting about pretending to be somebody else, and it can impact upon diagnosis and medical care, and also has impacts upon identity formation. And there's beginning to be a kind of quantitative literature that backs that up. So people who report higher levels of camouflaging tend to also report higher levels of depression and anxiety. So this has important implications because we cannot just make the assumption when we're helping autistic kids grow up, when we're offering social skills groups to people, that training autistic people to camouflage their autism is necessarily a good thing to be doing. It's much more complex than that, and we need to learn to listen more to autistic people so we can think in more sophisticated ways about things like social skills training and camouflaging. So I showed you the new consensus. So this is what I would consider the new consensus on autism, just to integrate some of that stuff we've spoken about with females. That here we have a relatively common neurodevelopmental condition with a gender-specific presentation, usually associated with normal range IQ, that represents a form of natural human variation, bringing both challenges and strengths. So I'm going to use my remaining few minutes just to move us now that we're equipped with hopefully a kind of up-to-date and contemporary sense of autism, but particularly of autism in girls and women, to begin to think about the topic at hand today, which is autism and eating disorders. And then after the break, Charlie and Janina are going to dive into that in much more depth and detail. So we know that autistic people very frequently experience mental health difficulties alongside their autism. So 70% of autistic kids also meet criteria for another DSM mental health condition, and we find similarly high rates amongst adults. What we're beginning to discover is that that pattern of co-occurring mental health difficulties has a gender-specific presentation. The boys, again, as in the non-autistic population, are somewhat more likely to have difficulties like ADHD, conduct problems, which is why I have a picture of a boy raising a chair above his head there. And the girls are somewhat more likely to experience so-called internalizing difficulties, anxiety and depression. But of course, based on the work of people like Professor John Morgan, Kate Chanturia, Chris Gilberg, we're also becoming aware that a key gender difference in terms of risk for mental health conditions is that if you're autistic and you're female, you appear to have a much higher risk of developing a restrictive eating difficulty and of being diagnosed with anorexia nervosa. Now, because time is short, I'm not going to labour this point because I'm really remaking a point that was made very, in my mind, convincingly by John before lunch, which is that, the story is that clinicians began to notice that it seemed like there was a substantial proportion of women who were being diagnosed with anorexia nervosa who also seemed to have an undiagnosed underlying autism spectrum disorder, or autism spectrum condition, rather. And this was an idea put forward by people like Chris Gilberg in the 80s. People went out and did the studies. The study started off not being massively high quality, but they've grown and grown in quality. And we've arrived at a point where, as John was saying earlier this morning, you cannot dismiss the finding of high rates of autism amongst women presenting with anorexia nervosa as simply some sort of artifact resulting from starvation, from having high levels of anxiety and perfectionism. The evidence, to my mind, doesn't sustain that interpretation. So the next step becomes thinking about, and I'm very much looking forward to John publishing those data. He was talking about that follow-up study because I think that's exactly what we need to know next. What are the clinical implications? What are the care implications of the fact that really large proportions of people diagnosed with anorexia nervosa have an underlying autistic condition? Well, we're beginning to get a sense of it from the research evidence. So first of all, the first point to make is it's almost always the case that these women present to eating disorder services undiagnosed in terms of their autism. So Charlie and Nina interviewed a bunch of women for their study they're going to talk about. I think all but one of them initially presented with severe restrictive eating problems and only subsequently was diagnosed with autism. So I think that's an important care implication. The certain longitudinal studies have suggested that amongst people with anorexia nervosa, those who have autism or higher autistic traits tend to have the worst outcomes. And again, there's some suggestive evidence from the Maudsley that those who are entering clinics with higher trait scores for autistic traits benefit the least from the treatment that they received. And I think it's very interesting and a little bit disappointing that despite the fact that the NICE guidelines for eating disorders were recently kind of revised, the word autism still doesn't appear in them once. Which is interesting given that we're saying, well, maybe as high as 20% of people presenting with restrictive eating problems in NHS services have autism. So, we recently were given some money by a charity called Autistica, which is like the UK's kind of main autism research charity. And it was to do a project to investigate anorexia nervosa in autistic women. And fundamentally, we had two goals. One was a sort of practical goal, and that reflects some of the things we've already heard about today. But we felt we wanted to try and understand, are there kind of practical barriers that are preventing autistic women from accessing and benefiting from eating disorder services. Things like, is the sensory environment on these units, does it make it impossible to engage with treatment? Are people routinely being asked to participate in group treatments that they can't tolerate and which actually don't help? So we're trying to systematically study that. And we're also trying to address the second question, which is what causes and maintains eating difficulties in autistic people? And here, we're very much interested in the idea that maybe, just because an autistic woman has been diagnosed with anorexia nervosa, maybe she doesn't really have anorexia nervosa. Maybe she has ARFID. Maybe she has something different. Maybe there are different autism-specific mechanisms that are driving her eating difficulties and impacting upon her health. And so, and if that is the case, and that's the kind of overall hypothesis we're kind of in the process of investigating, we really need to know. Because again, as John said, if an autistic woman turns up at the clinic with a very low body weight, and they get pushed into sort of nice guidance treatment, and they spend 16 sessions with a cognitive therapist dealing with their weight and shape concerns, and yet they don't have any weight and shape concerns, and they've actually developed their low body weight for very different reasons from a so-called quote-unquote conventional patient with anorexia nervosa. So that's what we're trying to do. We're trying to explore that terrain and see if we can almost build a model of the development of restrictive eating problems in autistic women. And Charlie and Yanina, after the break, are going to tell you about the first phase of that process. So what we're doing is in our first phase, which we're coming close to completing, we've done in-depth qualitative interviews with various people who have insights into this phenomenon, in particular autistic women with a history of eating disorders, and to build a model. And then in the next phase, which hopefully I'll be able to come back in 2 years' time and tell you what we found, we're actually going to test that model out quantitatively, using by measuring things carefully and looking at group differences. And so on. And so that is me creating, I don't know if you're going to be able to tolerate the suspense during the coffee break, because when we come back, Charlie and Yanina are going to start to tell you about some of the barriers that we've identified through our work, and also some of the ideas we have about building this model of eating difficulties in autistic women. Thank you.